discussions earlier. So the way we do it is we present the case, we give options, and depending on what they suggest, we will go on. And the thing is, it's a question of, basically we are looking at what's the evidence behind the practice, because all of it, as I said earlier, and as I keep saying again and again, everything has to be based on some data. We may not have data for everything, and we might have conflicting data for certain situations. But as long as you are doing it based on known facts, I think it's better for the patient ultimately. So the first one we're going to start off is I know, is going to be intrauterine fetal death in a twin, one of the twins. Right. So Mrs. PS, 28 years old, Gravida 2, Para 1, Live 1, presented at 8 weeks gestation. Her pregnancy was confirmed by clinical examination on the 11th of November. She presented 2 weeks later with dark brown discharge PV. A diagnosis of threatened abortion was made, and an ultrasound was done. The ultrasound showed a viable monochorionic diamniotic twin gestation at 9 to 10 weeks corresponding to dates. Now, this is very important that we have to start, we check and make sure that we know if it's an MC twin or a DCDA twin, right? So we'll start with you, Nirmala. This is a patient who has got twins. She's got MCDA twins, and she's had some spotting. Fetal heart rate is fine on ultrasound. There is the presence of cardiac activity. So you would, at this point, admit her to the hospital, place her at complete bed rest, suggest cervical cerclage. She's got twins, so maybe she requires cervical cerclage to keep the babies in. Place her on micronized progesterone, send her home with instructions for restricted activity and to avoid intercourse for 2 weeks. You can do all of them, none of them, any of them.
I think I would rather prefer to send her home with instruction for restricted activity and avoid intercourse for 2 weeks, because it's 8 to 10 weeks, right?
9 to 10 weeks,
yeah. Probably I may put her on some even micronized progesterone as well.
Right. Any reason you'd put her on micronized progesterone?
Probably it's around 10 weeks. That's a taking where the placenta is taking over. That's the time she started having this spotting. Maybe it's an indirect evidence of reduced progesterone activity. Maybe it's better to put her on that. Maybe it's an empirical way, but then it's better with the twins. It's better to put that way.
Right. Dr. Piley, do you agree with her?
My choice is only the last one, that is send her home saying that of restricted activity and to avoid sexual contact. That's the only thing. I would not put her on progesterone at that point. Yeah.
Arul, what's your take on this, the micronized progesterone?
Well, there's some evidence for progesterone use, but in this particular case, I don't know how effective it's going to be. So, in practice, it's partly evidence, partly what the patient wants as well. So I will have some discussion with her. And if she is happy to go home and rest without sexual intercourse, I will ask her to come back and do another scan. Right. But if she is very anxious, I'm happy to give some progesterone. It's not going to do any harm, but whether it's going to be beneficial is a question mark.
It may not do any harm, but it's very expensive. Micronized progesterone in India is expensive.
Okay, if the patient says I'm going to afford it, then she says I can't afford it, then
even drivers' wives who are earning very little will afford it if they feel that it's going to do something. So you're right. If you feel that it has some, it might help. Sangeeta, Serena, either of you?
Last choice, send her home. Send her home, instructions for restricted activity, counselor, and I'd like to see her in 3 weeks' time.
Right. Serena, the same?
It's a spontaneous conception, then
it's a spontaneous. So if it's an ART pregnancy, probably there might be, she would already be on progesterone, there's no question about it. Right. So we admitted her to the hospital for a day. There was no bleeding after admission. We sent her home with instructions for restricted activity and to avoid intercourse for 2 weeks. At 20 weeks gestation, a complete obstetric scan was done. It showed twin A as having a lateral ventricle of 1.1 centimeters with an occipital horn measuring 0.9 centimeters. At this point, since there is ventriculomegaly, Nuzhat, you came in just for my perfect question. So since you're last on stage, you're going to be the first to answer this question, Nuzhat. So this is a twin pregnancy. She's had some spotting at 9 to 10 weeks, and now she's 20 weeks, and it shows that twin A is having a lateral ventricle of 1.1 centimeters with an occipital horn measuring 0.9 centimeters. So with the ventriculomegaly, isolated ventriculomegaly, would you suggest termination of the pregnancy? Would you counsel her about chances of hydrocephalus, counsel her about chances of Down syndrome, counsel her about chances of CMV or toxo-infection?
I wouldn't be terminating pregnancy for her. It's an isolated finding of one lateral horn of 11 millimeters. So I'm just going to do a thorough TIFA scan, maybe an anomaly scan, and see how it would.
At 20 weeks, everything else was normal. This was isolated.
I would follow it up.
Just follow it up, right. So, so now you said that you'd follow it up. When would you repeat the ultrasound?
She's 20. Maybe I would go across to 26, 28 weeks.
Right, okay. So, in isolated mild ventriculomegaly, counseling may be a challenge because the prognosis can be variable. 30% may have developmental delay. But again, it's very difficult. So we have to tell them that it is there, but we certainly do not offer termination of pregnancy. And as Nuzhat suggested, we did repeat the ultrasound after 6 weeks at 27 to 28 weeks gestation. Twin A, the one with ventriculomegaly, showed intrauterine fetal death. There was Spalding's sign and particulate matter in the amniotic fluid. Twin B showed normal growth, normal amount of amniotic fluid in the sac, and a normal Doppler study. We know that the majority of cases of death of one of a twin occur in monochorionic twins, and this was a monochorionic twin. And there's a 3% risk of losing the other twin. Anywhere from actually a little higher. Dichorionic twins have a 3% risk. Monochorionic have a 15% risk of losing the other twin. When it's same-sex twins, it doubles the risk of, same-sex twins have a double the chance of losing the other twin as compared to opposite-sex twins. And if there is discordance, it increases the risk. And there is a smaller degrees of discordance in the same-sex twins also increases the risk of demise of one twin. This patient actually had come to us from Delhi, and her parents got absolutely panicky because one baby had died and they wanted her to come back, but she was comfortable with our care. She stayed on with us. Serena, would you at this point discuss the chances of DIC, chances of complications in the remaining twin, discuss termination of pregnancy? She is 28 weeks right now. Discuss termination, discuss continuing the pregnancy.
Now, yours is a monochorionic diamniotic twin, so I will give it a little more care than I would a dichorionic diamniotic. But the one thing I would think of was a TTTS, but you said the Leica volume is normal. There's no polyhydramnios, oligohydramnios sequence.
Nothing.
Another condition when which can go for a death is when there's an intrauterine growth restriction, which is also not said. Another chance could be chromosomal abnormality or a congenital abnormality. It could click in one of those two. So I'll not discuss the chance of DIC, it's very rare. Discuss the chances of complications in the remaining twin. Not exactly, probably I would prime them that we have to monitor closely because it's a monochorionic pregnancy. Not discuss termination now because 27 to 28 weeks of borderline, I would rather carry on for some more time. Yes, I would continue the pregnancy with close monitoring.
Any of you would like to terminate the pregnancy? Dr. Piley, you want to say something?
No, not to terminate the pregnancy, but I will put her on a weekly platelet count to know whether this dead fetus inside is affecting in any way. Otherwise, of course, APTT with the platelet count would have been, but platelet count is supposed to be the best guide of any effect on that. Otherwise, the effect of that single demise on the other fetus, if at all anything, is already over, and we are not going to worry or achieve anything by worrying about it.
Right. Because when the twin dies, there's an extraordinary amount of hypotension, ischemia, anemia happening in the remaining twin. But it's that particular instant at that point. So if the baby is going to die, it's going to die then. And if it has survived, I don't think we need to do anything more about it. Sangeeta, would you think there's anything, other problems that can occur in the remaining twin because of the sudden demise?
At that point, yes, but if she continues this way, because she's a monochorionic pregnancy, the risk, even though the IUFT has occurred, the risk would still remain because of probably placental anastomosis. So I'd keep her on a more close follow-up and mark it off as monochorionic, and that the baby would probably need a better follow-up.
Right.
But take her on as per the twin protocol.
Right. Arul, anything else specific for the remaining twin? Would you be concerned about?
No, I think because the death of the twin, as you know, in monochorionic, once it happens, there is a hemodynamic disturbance. That's why the second twin is going to be affected. So if it's going to get affected, it has already got affected. The second time it might get affected is if it is going to throw up some coagulants and problem like that. So I would just monitor her, monitor the baby,
Right.
just to see the baby is growing, and especially the brain, because
Right.
if there is any thrombotic effects, it might show as some
Right.
periventricular hemorrhage or leukomalacia or something. So I
Right.
wouldn't, I would warn her saying that it's not 100%, but if
Right.
nothing has happened, and just continue monitoring and carrying on with the pregnancy.
Right. If she was 34 weeks, Nirmala, what would you do? Suppose she's 28, 29. As Serena said, borderline.
If it's 34 weeks, then I would like to give her a dose of steroids and think about
delivering
termination.
her. Because we may or
Yeah,
may not
yeah,
achieve
may not. And
anything,
there's
but at
no-
28
yeah.
weeks, we definitely
That's
will
true.
lose
There's
the
no point
other
in-
baby.
yeah,
Yes,
that's
right. Okay. So when fetal demise occurs after mid-gestation, there is a 17% chance that the surviving twin in a monochorionic gestation will either die or suffer major morbidity. 17% chance, which means there's an 80% chance, almost a little more than 80% chance that the baby will be normal. So this is the counseling that we have to give our patients. We have to tell them, yes, there could be a problem. Either the baby could have died right away, which didn't happen, or if it does survive, because of the thrombotic events, because of the embolization, you might have brain damage to the surviving twin. You might have Malaysia, you might have, as Professor Arul Kumaran said, you might have some hemorrhage. So these are the things that you have to follow up, because you will tell the patient that 80% this surviving twin is going to do well, and we don't have to get too excited about it. Right. Prompt delivery has not been shown to prevent pre-existing neurological injury or injury that occurred at the time of the co-twin's death. Delivery for the purpose of preventing injury versus risk of premature delivery, you have to think about that, because you're not going to prevent any further injury. It's already done. Whereas if you deliver the baby prematurely, great chance at 28, 29 weeks that you might lose this baby. After discussion with the couple, a decision was made to continue with the pregnancy. You would perform an ultrasound every week, every 2 weeks, or after every 4 weeks, Nusrat. And would you get a baseline coagulation profile and repeat it every 2 weeks? I think Dr. Piley already said he would do the platelets every week. Would you admit the patient to the hospital at this point? Advise bed rest at home? Perform weekly NST-AFIs on the live fetus?
I would get an ultrasound maybe 3 weeks later, not every week, just to know. I also would include an MRI maybe about 4 to 6 weeks later to know if the baby is affected, and maybe we can prognosticate. It may not change after 28 weeks, but we would just have an idea that this baby is not. Baseline coagulation profile, we would do it previously, very regularly. But now we have moved it down. There's not much of evidence to say that every week you need to do. So we do a baseline at the time. And when she comes for a delivery, definitely we will do a baseline again to see that do I need a correction. Wouldn't require an admission to the hospital, and I wouldn't say bed rest. Perform weekly AFI and NST on the live fetus. After we actually put it after 32 weeks, and that's the way we would go. 34 weeks we would aim for a delivery.
Right. So the DIC is very, very uncommon, isn't it? So doing a baseline coagulation profile at the time of the thing, maybe just to get your baseline numbers. But again, as Nusrat said, just before the delivery, maybe you do your baseline and just getting your coagulation profile for the mother, just to make sure that she's not actually one of the very, very rare patients who are going to have the DIC. And then you decide on your delivery. And as you said, probably we would aim for about 34 weeks. Right. A baseline coagulation profile was obtained and was normal. She was asked to repeat it every 2 weeks. An ultrasound was repeated after 4 weeks, 31 to 32 weeks. No antepartum, and I don't think we needed to have repeated it every 2 weeks. Right now, as of now, I would not repeat it. This is what we did, but probably this is not the right thing to have done. An ultrasound was repeated after 4 weeks, 31 to 32 weeks. No antepartum testing was done, but the patient was asked to perform daily fetal movement count. She was just asked to, because obviously she was also anxious, and this gave her something to do, actually count the movements and have her own reassurance that the baby was doing fine. The coagulation profile remained normal and the patient perceived good movements. At this point, Sangeeta, would you plan delivery at 34 to 35 weeks? I think Nusrat has already voted 34. Delivery at little later, 36 to 37 weeks. Allow spontaneous onset of labor, induce labor. Schedule her for an elective cesarean section. She's a gravida too.
She's had a previous
Normal delivery,
The
yeah.
placenta must be up. It's not a lower segment
No,
placenta.
no.
There is no need to do an elective cesarean section, definitely. But at any time after 34 weeks, I may even push it to 35.
Right,
I would induce and deliver.
right. Nirmala, would you wait longer than 34 weeks, 35, 36, 37?
I think there's no point in waiting beyond, maybe at the maximum to around 36 weeks. And
Right.
up then, yeah, then I think it's better to induce her and allow her
Right.
to deliver.
So,
yeah.
yes, Nusrat.
Yeah, you have a different.
It depends on the neonatal facilities that you have. Our salvage rates at 34 weeks would be almost similar to that of 37, 38 weeks. So we usually, for
Can you increase the
monochorionic
volume?
twins, we put it at 34 weeks with a single fetal demise.
Okay.
Because we don't achieve much more by keeping the baby inside, and I think it depends on individual facilities that you have.
Absolutely.
I mean, I would go up to 36 weeks if nothing else happens. That's because of the balancing the risk and the benefit for the baby rather than anything else. Taking out a 34 in our setup is still, adding problems and cost also very much.
Right.
The neonatal intensive care stay is on the rise. Salvageability is there, but at what cost is the question. Of course, and again, even if we say that at 34 weeks we have, say, 90%, 95% salvageability, there's a lot of stress on the family, on the way, and some other things which we don't know. Intensive cares. So that's why we would
As you
prefer to
said,
go to 36.
NICU costs are anywhere from 8,000 to 10,000 rupees a day in Chennai. I don't know how much it is elsewhere. You don't know? It's much more now. You're saying it's much more. Yeah. So, you're going to end up adding, as Dr. Paili said, costs are going to go up. So, it's an individual call. It's an individual call.
I think we shouldn't blindly just because the baby has reached 34 weeks, we shouldn't think about it, because at least in our ordinary government hospital settings, we can go by the rule that even 1 day of intrauterine life increases survival by 3 to 4%. So close surveillance at any point you feel that the intrauterine environment is really dangerous for the baby, take the baby out. But we can't just, as you said, it depends on your center, but it's preferable that if possible with good surveillance, you can continue the pregnancy to a little more reasonable period for survival.
Arul, what would you do in the NHS?
Well, in the UK, we don't interfere. We just leave them alone because there's no randomized controlled trials of one versus the other, early intervention, late intervention. There's no prospective study to say every week there's a percentage increase. So really, we are postulating, thinking somebody is going to hit me, let me run away, but nobody might hit you.
Right.
So generally our tendency is to wait till 36, 37 weeks and then
Right.
induce at that stage.
Right. And I know that in private practice there's a huge amount of pressure. You'll get phone calls from the uncle in Canada will say, why haven't you delivered now that it's 34 weeks? In Canada, we can save babies at 34 weeks. Why aren't you delivering? So there will be a lot of pressure. But as Arul said, we don't have any evidence to say that, after this once that first problem occurred, when that first baby died, that's when something bad would have happened to this baby. If it was going to die, it would have died then. We don't know if that risk increases as the days go by. So I think maybe waiting may not be. I think the panel believes that we should wait. So at 36 to 37 weeks, the cervix was 50% effaced, os was posterior and patulous. The vertex was at -3 station. The AFI was 15.4 centimeters. Induction of labor was planned. Cervical ripening was scheduled after 4 days. We said we touched 37 weeks. We are happy with the maturity, lung maturity of the baby. The mother is happy, and we said, okay, 37 weeks. On admission, the cervix was 50% effaced, os was 2 to 3 centimeters dilated, and the vertex was at -3 station. The labor was induced. The patient went into labor 2 hours after initiation of labor and delivered 2 hours after the onset of contractions. Very quickly, she went into labor and she delivered. A live female baby weighing 2.35 kilo was delivered, and a macerated female fetus weighing 450 grams was then expelled. And fortunately for all of us concerned, this girl is developmentally normal. She's absolutely normal. She hasn't had any problems at all. And I think the panel should be applauded for giving us a normal, healthy baby, to walking us through this. Right. So, sorry. We'll go to the next case. Right. This is a patient with antiphospholipid antibody syndrome and with growth restriction. And this is a problem that we all face, and there are a lot of questions which come up and I see a lot of things which are done, sometimes for the right reason and sometimes for the wrong reason. So Mrs. B.A. was 34 years old when she first met us. She had regular periods. She had been pregnant 6 times. She was a para-zero. She has had 5 pregnancy losses and 1 ectopic. All 5 abortions were missed abortions before 12 weeks. At this point, and I'm going to throw up a lot of things because they are being done even today. Sarina, would you like to go through this list and tell us what you would or would not do?
She has had 5 pregnancy losses and 5 apparently after fetal heart activity has been established. Torch panel, no, because it's never done for a recurrent abortion.
I think, Sarina, you have to say that loudly and yell it out, because I've seen patients where the husbands have been tested for torch. They've been, it's like, so maybe, I don't know whether that doctor owned the lab, I don't know. But even the husband was being tested. So it's very clear, we don't do torch tests, not for RPL, right? Would you do a GTT?
Yeah, she's 34 years old, and so I would do a GTT.
Would you do that because she's had recurrent pregnancy loss or because she's 34 years old?
She's 34.
Because she's 34 years old, correct.
Okay.
Yeah.
And now she said karyotyping for both the partners. It's a late loss, so I don't think that will help us much. It would probably have helped us in a very early loss. The chromosomal abnormalities are much more than. Test for, yes, definitely I'll test for ACL antibodies, APTT. Thyroid function test, yes, because there's a high incidence of thyroid abnormalities among us. Ultrasound of the...
So are you doing the TFTs for the RPL?
Not for the RPL, but because there's a high incidence.
Because she's there, and anyway, you might as well check for hypothyroidism.
And whenever there is a thyroid loss, it's always in the first trimester. Ultrasound of the uterus, yes. HSG, yeah, maybe if I do a 3D ultrasound, I could probably find out whether there's any abnormality in the uterus. And if I've got a doubt, yes, I will do a HSG.
Okay, fair enough. Right. The karyotyping was normal for both, and torch panel was not done. A 3D ultrasound revealed a normal uterine cavity, and the ACL, anticardiolipin antibody, IgM, was significantly elevated. Soon after she met us, with our encouragement, she conceived spontaneously because we told her that there is treatment possible and you have a condition which we can treat and we can help you try for a baby. So now she was a Gravitas 7, live 0. Nusrat, any of these? None of these? All of these?
None of these.
None
Easy
of
for-
these.
None of these.
Oh no, okay, right. So I think the message has to come across clearly. Any of you feel that we should be using any of these? Because I'm seeing micronized progesterone being, coming on the screens between talks. So there must be a market for it, obviously. So any of you would consider micronized progesterone in her? In this particular case? Okay, right. HCG, none of these, obviously. Yes, Dr. Pandey.
Not about the micronized progesterone, but the IgG was negative or only IgM positive?
IgM was positive.
Only IgM.
Only IgM was positive.
Because she had a prolonged history like that, I would have expected IgG to be.
Not ACL. They say either way can be, either one can be positive, and you have to take that as a positive, this thing. Sangeeta, you wanted
But
to say something?
with this kind of a history, very many people would start on heparin.
I can't, yeah.
Sorry. Very many people would start. No,
Put
no.
it against your mouth, literally. Can you increase the volume, please?
The thing is that the ACL being a sole elevation could also be as part of an acute phase reactant. That's why it's recommended that it's looked at 12 weeks apart. The same test is repeated because small elevations of these can
This was
be.
significantly
Yeah.
elevated, and she's had pregnancy losses at after 10 weeks of, so it was everything together. It's a combination.
Geeta, still I thought the advice that you repeated to know
Yes,
whether
yes,
it is sustained.
Yes,
yeah.
yes.
Because the higher the elevations of these, it would prompt me to look for autoimmune disease as well. ANA, dsDNA.
If she is 34 years old, she would have shown other, I think, she would have shown symptoms. Yeah, but she would have, you're talking of secondary APLA, she would have shown other signs of SLE. If it's going to be secondary,
They may just have a very quiet.
you have to use the mic.
I
Sangeeta.
always believe I'm loud. That's
Yeah.
the problem.
You believe you're loud, I am loud.
The thing is, some of them remain quiescent only to throw up in pregnancy. So if there were very high elevations, yes, and autoimmune screening, now we are seeing a lot of autoimmune disease.
Right.
A
For
lot.
RPLs, in fact, there is no evidence that you look for ANA, dsDNA, unless clinically you feel that there is symptoms of SLE.
Yeah, even I would like to join what Sangeeta says, but in our part of the country, actually, we are seeing many women just with recurrent pregnancy loss. Then we investigate and we find them to suffer from other autoimmune diseases. So it happens to be a secondary. So we have not seen, even I have recently one patient, she's around 38 years. Only positive history she had was recurrent pregnancy loss. She had lost 4. So as part of our, now it's almost like our hospital policy to investigate for
Begin to their
that.
renal function, you may find something.
Yeah,
Right.
they may not be
Proteinuria
symptomatic.
in the absence of hypertension very
Yeah,
early
yeah.
in pregnancy.
Yeah.
That prompts you to think, are the
Yes.
kidneys
Right.
also?
So are
Yeah.
you saying that for all RPLs you should do?
No, in a case like this, whose ACL
IgM
is
alone.
very high, or probably also in the case whose APTT is extremely high.
Yeah.
APTT and APLA does not go to the range of 70 and 80. But if it is that high, yes, I would ask a
I don't know if it
hematologist
was
for help.
70, 80. I know it was significantly raised, and we said we found the cause.
No, the
of this.
APTT, even the APTT
Yeah.
in pregnancy with APLA doesn't really go to that
No,
high
it
levels.
doesn't, it doesn't,
So
it
if it is that high, I would screen for autoimmune disease.
Autoimmune. Fair enough. Okay. Arul, do you have anything to add to that?
No, I'm a very simple clinician. So generally we have found two spectrum of diseases with these antibodies. One is actually the recurrent miscarriage. The second actually is they have IUGRs fairly early. And the third variety is thromboembolism, thrombosis
Right.
and thromboembolism.
Right.
So any one of these coming, whether it's just recurrent pregnancy loss or recurrent pregnancy loss and IUGR before or thrombosis, then we normally start them on heparin and aspirin.
Right.
Because that seems to
Right.
have a blanket shot.
Right. And even early onset preeclampsia.
That's right. Yeah.
Right. So any of those could set you off into investigating for the presence of APL
Yeah.
antibodies. So she was asked to continue normal activity. She was not given any progestational support. In fact, there is no indication for progestational support in recurrent pregnancy loss. There was a Cochrane data review which said that progesterone might help in recurrent pregnancy loss, but if you look at the paper actually, there are 3 studies on which they have based this recommendation of studying more. They said we should check more to see if progesterone will help. And all those studies, their very numbers are extremely small and they were all done before 1964. So as of now, I still don't think there are any studies which prove that progesterone has a role in RPL. Is there any study that I'm missing? Okay, right. Right. As treatment for the antiphospholipid antibody syndrome, you would suggest low-dose aspirin plus unfractionated heparin, Dr. Piley, or low-dose aspirin plus low molecular weight heparin?
I am going for low-dose aspirin plus low molecular weight heparin. Unfractionated, actually, even though the initial cost for the heparin is less, when you think of the whole monitoring, it is going to be more. Whereas here, with low-dose aspirin and low molecular weight heparin, that intense monitoring is not required, and so my choice is that. Having said that, we modify actually a little bit. Cost considerations, of course. I give 100 milligrams of aspirin and 3,000 units of heparin daily. That is the way, because at 10,000 unit you get an ampule, you give it for 3 days, or pre-filled syringe, we can use it like that. I mean, yes, but principle, aspirin plus low molecular weight heparin, not unfractionated heparin.
Right. Any of you, Nusrat?
Sometimes we get people who can't afford low molecular weight heparin at all. So we do start on unfractionated, and that would be dependent on body weight. So 0.5 mg for low molecular weight, it would be 0.5 mg per kg body. We are using a therapeutic dose, so that's why I would start after confirming viability.
Right. So, in fact, most of the studies on treatment of APLA has been done with unfractionated heparin, much cheaper, and we have used it. The only problem is it has to be given twice a day, 5,000 units twice a day, as compared to low molecular weight heparin, which is 5,000 units once a day. So that's the only reason, and cost is much less. And we do use the vial, I'm going to say the brand name, they don't pay me, I'm not advertising for them, but Fragmin comes as 100,000 units, and we give it to them, and they say that you can't use it for beyond 10 days or something like that, but it lasts you for about 14 or 16 days, I don't quite remember, and it works out much cheaper than taking the pre-filled syringes. Pre-filled syringes are fairly expensive, right? So, right. Okay, so low-dose aspirin between 75 to 81 milligrams per day, 100, 150 have been tried. In fact, just giving the aspirin alone can result in live birth rates of 42 to 80%. Aspirin is started at the confirmation of pregnancy at 40 to 45 days. Would any of you start them on aspirin before you've got the report, and before she gets pregnant, would you start her on aspirin? Would any of you start her on aspirin before?
I don't think there's a role for any. You talk about pre-pregnancy aspirin, said so. No, we don't have the practice of starting pre-pregnancy, but once the pregnancy is confirmed, live pregnancy, then we start them on.
Any of you disagree with her? Would any of you would like to start it pre-pregnancy?
Folic acid, of course, not aspirin.
Okay.
Shyamala madam.
Anybody else? One hand went up. Any reason why you would use it pre-pregnancy, ma'am?
Because anyway, you are going to start it after pregnancy. So whatever good effect it has got, it is better that you start pre-pregnancy. That is, I used to start pre-pregnancy and heparin once the fetal heart appears.
Right. Does aspirin have any effect on the antiphospholipid antibodies?
Actually, effect is mainly on the platelets. And it is always better, I mean, we don't know when she's going to become pregnant. So as soon as she becomes pregnant, pregnancy test is positive, we start her on low dose aspirin.
Right. So basically it has an effect on the placental
Platelet
flow
adhesion.
and the platelets and the thrombosis, so microthrombi. So I think once she's pregnant probably is the evidence, that's what it says, that you start then. You continue it until, till delivery, and you stop 1 week before the planned delivery. So it's not started before pregnancy, and it's started as soon as pregnancy is confirmed. And again, there is this thing about you can start it as soon as you get a positive pregnancy test. You don't start the heparin till the heartbeat is seen. But aspirin you can start by 45 days if it's positive, because you just take it, and if she starts bleeding and she's not pregnant, then she can always stop it. So the evidence for aspirin plus heparin is that the live birth rate can go up to 71 to 84% when aspirin is combined with heparin. And as I told you, you have to give unfractionated heparin, 5,000 units BID. It's less expensive. And as I said, these are the studies actually which for APLA syndrome before they started using the low molecular weight heparin. So low molecular weight heparin, dalteparin, is used 5,000 units daily. There's a less risk of thrombocytopenia. As Dr. Piley said, with unfractionated, you have to monitor them regularly for platelet counts, because it is not dose related. It can happen anytime in pregnancy that their platelets can drop very, very drastically. And I told you about Fragmin. It comes to about 8,000 rupees per month. So now you would follow her, Sangeeta, with which ones would you follow them with?
If she's on low molecular weight, I would just leave her alone because she doesn't need any monitoring. But yes, with unfractionated heparin with platelet counts and APTT probably. APTT may not, platelet counts every week.
Right.
Or once in 10 days.
Right.
And APTT maybe once in 2
Right.
weeks.
We had an extremely poor patient who could not afford low molecular weight heparin, and she was taking unfractionated heparin. Both pregnancies, her platelets just dropped drastically. She just would not, so it was very, very sad because she could not, though we tried to help her, we said,
Normally, you get something called HIT, which is heparin-induced thrombocytopenia, normally seen within the first 2 weeks. So very close monitoring is required as soon as you start the patient on any heparin for the first 2 weeks.
Yes, right. She was followed with PT and INR and platelet counts monthly. The routine ultrasound, though low molecular weight heparin, the platelet counts may not drop, but there still is a chance that it can happen. The routine ultrasound at 20 to 21 weeks was normal. All fetal parameters were normal. So there we know, as Professor Arul Kubran said, there's an increased risk of preeclampsia, there is increased risk of growth restriction, prematurity, fetal distress. All these can happen as part of the APLA syndrome, not just the fact that she's on any of these medications. It's got nothing to do with the medications. It's just part of the spectrum of antiphospholipid antibody syndrome. Serial scans were done at 33 weeks. Growth restriction was diagnosed. The amniotic fluid index was normal. It was 11.4 centimeters, and her blood pressure was normal. And she's now 33 weeks. Obviously extremely anxious because she's lost so many babies, and now she says one more problem has popped up. Nirmala, would you discuss the delivery with the patient? Admit her to, that is, discuss delivery with the patient, that we'll start talking about getting the baby delivered. Admit her to the hospital for complete bed rest. Give her steroids for accelerating fetal lung maturity. Place her on L-arginine. Give her 2 hours of oxygen every day by mask. Put her on a high protein diet.
I would like to give her steroids for accelerating lung maturity, and her Leica volume is around 11 something.
Yep.
So we have a scope that we can wait for some more time. Maybe it depends on the extent of this IUGR. I'd like to do a Doppler and other things and do a fetal testing rather than discussing delivery immediately. There's a good prognostic sign is a Leica volume. That mean.
Right. You don't want to put her on L-arginine?
No,
Or
I
any-
don't put her on L-arginine, I don't put her on, maybe I would put her on some high protein diet because this is hyperplastic stage where it has developed. It's also important that she started her growth restriction after 28 weeks. So maybe either the placental problem or maybe she's not taking food. I would like to see her weight gain also. I would like to know whether her supply of
If
this
she's
is
had
fine.
normal weight gain, you wouldn't worry too much about the high
Yeah,
protein
that's
diet.
true. Yeah, if the weight gain is not proper or it's less, maybe I would think about high protein. Anyway, I don't put her on any of those things.
Amino acid drips?
Why should I? Because I don't, but I feel that there's no rationale for all that. Yeah.
Amino acid drips, anybody? Is anybody on the OBGYN discussion on Facebook? The Forum for Obstetricians Gynecologists? So what is the recommendation of most doctors for anything, including hypertension, growth restriction, prematurity? They put brand names of amino acid drips. There have been 3 studies which are quoted, and the amount of amino acids, what they give is extremely high, and those studies are not reproducible, and we are not giving that. What's available commercially, I'm using a Royal General we, I don't. So what's available commercially is extremely small amounts of amino acids which you can get from a handful of dal or vegetables or whatever, wherever you get amino acids, probably from dal and stuff, proteins, an egg. So it's very expensive, so I would strongly urge people not to buy that and give that. They're 300 plus rupees per IV drip. So Nirmala, I agree with you. There's no need for that. Oxygen by mask, you do not agree. Arul, you've got the mic and you want to say something.
No, I'm just thinking we don't do any of these things in the UK. Maybe the NHS is poor.
You're an undeveloped country.
We are an underdeveloped country, I'm practicing.
You're not underdeveloped, you're just undeveloped.
Undeveloped. The only possibility is, if you are concerned, if the Dopplers are okay, then I wouldn't even think about the steroids. So in addition to the amniotic fluid, if there's a Doppler, I'll do the Doppler. And when the Doppler shows some change, that's the time I will go for steroids.
Right.
Otherwise, I would just not take any of these.
Right. Dr. Piley?
I was just asking Professor Piley about L-arginine.
Oh, it's a huge bestseller.
Maybe it's good for the obstetricians to have a grip.
There are some hundreds of brand names. If you go and look for amino acid preparations in India, there's not one, there's not 40, there are hundreds of brand names. Hundreds. We need some political will in this country.
No, actually, when I was looking for this, it was even shown that amino acid drips can be positively harmful to the fetus regarding its growth. And regarding the one point I would add to this lady is, I usually tell them to have rest for about a couple of hours in the afternoon. Just lie down flat onto side with a side. And that's the one addition I would give for them. No, oxygen by face mask, all these things, that we thought probably earlier we thought giving more glucose is useful. To animal studies were done giving glucose directly to the amniotic fluid and to the fetus. Studies were done with the amino acid injection into the amniotic fluid as well as, of course, to the mother. All these have shown that they do not work, and some of them positively harmful. So better not to go for any of these, but for her to take rest for a couple of hours every day during the daytime, rather than be on her toes, really, maybe even otherwise helps her in her morale.
The only thing I would like to tell Professor Arul Kumaran, because he doesn't know about these good obstetric practices, is that In India, if a woman has lost 7 pregnancies, she has not gotten out of bed. For the past 33 weeks, she's probably her mother-in-law, her mother, everybody is holding her down and saying, don't move. And we are telling her, you can go to work, you can do everything. Chances are that she's already not only resting in the afternoon, she's resting in the morning, she's resting in the evening, she's resting through the day. But again, something that came up on one of these discussions is that there is an IVF specialist. I will finish in time, Jay Krishnan. I've got 5 more minutes. IVF specialist who puts everybody on head down position for the entire pregnancy, and they all require physiotherapy afterwards because their muscles are completely gone. They get bed sores and they get DVTs. So I put it out there that his name should be out there and we should sue him for malpractice. So there is no need for bed rest other than, as Dr. Piley said, lying on their sides in the afternoon, just a little bit of increasing the oxygenation to the baby, the blood supply to the baby. Right. Delivery was discussed with the patient. She was admitted to the hospital for steroids. She was ambulatory in the hospital. You would check fetal well-being with fetal Doppler, perform AFI NST every week or bi-weekly. Now, we gave her steroids only because of the stress about the fact that she has lost 7 pregnancies, and if for whatever reason she did anything immediately, we would not have lost that chance. As Professor Arul Kumran said, it will be perfectly all right if her Doppler is fine. We could definitely wait. There's no question about it, because steroids are a gun with a single bullet. Once you use it, you can't use them again. So I think we can definitely wait on the steroids if you want to. So at this point, you would check fetal well-being with fetal Doppler. I think that everybody said we do that, and perform AFI NST every week or bi-weekly, Nuzhat?
It depends. Right now, the situation is we have got fetal growth restriction with normal Doppler and normal amniotic fluid.
No, we don't know the Doppler yet. I haven't told you.
Yeah, but if it is normal, then I would go for weekly.
Okay.
But if it is any other change, it depends
on whether it's bi-weekly. Right. Doppler studies at 33 weeks were normal. You would repeat Doppler studies weekly now, or repeat Doppler studies every 3 days, Nirmala?
Yeah, if Doppler is fine, then I think we can do a weekly. We need not do it every 3 days.
Okay. Yeah. Any of you? Weekly? Yeah. Okay. Right. Doppler studies were done weekly to help with the decision for timing for delivery. The umbilical artery and MCA Doppler flow stayed normal till 34 to 35 weeks. At 35 weeks, MCA Doppler showed brain-sparing effect, and the umbilical artery showed decreased diastolic flow. The NST stayed normal. AFI was 6.7 centimeters. At this point, would you deliver immediately? Would you induce? Would you do a cesarean? By the way, she's 4 feet 6 inches or 7 inches tall.
I think,
follow her with NST and AFI, stop the aspirin, stop the heparin.
Yeah, I think it's, with this picture, I think you can induce. I feel it's better to induce rather than waiting for all the reversal and all the another chronic hypoxia to develop. We could do a vaginal exam, see her cervical score, Bishop score is fine. Based on that, either we go for a priming or cervical priming or induction. And then I don't think
there's she was 35 weeks.
Yeah, 35 weeks.
Right.
Yeah, then with close monitoring, then deciding on cesarean as in, this is what I feel. This is what I would like to.
Anything? Dr. Piley?
The aspirin. And she has IUGR and she has an abnormal Doppler. I won't go beyond 37 definitely, but at 35 to 37, if the ductus shows forward flow, the A wave is normal, I would keep her to 36 to 37 weeks.
Ductus is normal because it's only MCA brain sparing, and the umbilical artery just shows increased diastolic flow.
I will wait to about 36 to 37 weeks.
Right. Any of you want to deliver?
No, but you must also remember AFI is also dropping now. AFI is 6.5. So, because I think 36 weeks will be a good cutoff. because we may not be able to take her as far as 37, and then at that time, if you have not given her steroids, ideal time to give steroids is 1 week before the expected time of delivery, and stop the aspirin, of
Oh,
course.
but we've crossed 34 weeks. Would you still give her steroids?
Ma'am, we would have given her. We would have given her even as far as 36 weeks.
Okay.
We give it as a routine because especially this growth restriction, it does reduce intracranial hemorrhage and necrotizing enterocolitis apart from RDS. And heparin, yes, depending on what I've been using. If it was low molecular weight, we would have stopped 24 hours before the induction, and otherwise 6 hours before.
Dr. Paili.
I know, Geeta, you are not to give steroid beyond 34 weeks. That may be the reason. But, you know, recently the RCOG has come up, give up to 39 weeks for elective cesareans.
They're an undeveloped country. We've established that.
Yeah, but I have friends, neonatologists working there in the UK, who all along had been saying that they will continue to give up to 36 weeks, even when they were all in the literature saying 34 weeks, you stop it. So you faithfully follow your 34 weeks.
No, because ACOG, I'm a strong,
I
I come from the other side.
Yeah, the Atlantic makes a difference, but for us, I think we have always felt that 36 weeks should be the time till when we will continue it. And so
Arul, you wanted to say something on this?
No, I mean, she is 34 years old and she had, this is the 7th pregnancy. And in conditions like proteinuric hypertension and antiphospholipid syndrome, the situation can change overnight. Unlike a simple, straightforward IUGR, things can change. So my inclination would be to stop the drugs which is going to cause bleeding, give the steroids because both will take 24 to 48 hours and then deliver her. The question whether it's cesarean or vaginal delivery, if the cervical score is very poor, the chances are very high, then I would deliver by cesarean section.
Right, okay. I'm almost done.